National Library of Medicine, Inflammageing, Chronic Inflammation in Aging, Cardiovascular Disease and Frailty. September 2018. Most older individuals develop inflammageing, a condition characterized by elevated levels of blood inflammatory markers that carries high susceptibility to chronic morbidity, disability, frailty, and premature death. Potential mechanism of inflammageing include genetic susceptibility, central obesity, increased gut permeability, changes to microbiota composition, cellular senescence, NLRP3, inflammasome activation, oxidative stress caused by dysfunctional mitochondria, immune cell dysregulation, and chronic infections. Inflammageing is a risk factor for cardiovascular disease, CVDs, and clinical trials suggest that this association is causal. Inflammageing is also a risk factor for chronic kidney disease, diabetes milieu, cancer, depression, dementia, and sarcopenia, but whether modulating inflammation beneficially affects the clinical course of non-CVD health problems is controversial. This uncertainty is an important issue to address because older adults with CVD are often affected by multimorbidity and frailty, which affect clinical manifestation, prognosis, and response to treatment, and are associated with inflammation by mechanisms similar to those in CVD. The hypothesis that inflammation affects CVD, multimorbidity, and frailty by inhibiting growth factors, increasing catabolism, and interfering with homeostatic signaling is supported by mechanistic studies but requires confirmation in humans. Whether early modulation of inflammageing prevents or delays the onset of cardiovascular frailty should be tested in clinical trials. With the extension of life expectancy and the rising percentage of older individuals in the general population, understanding why aging results in progressively higher susceptibility to chronic morbidity, disability, and frailty has become a public health priority. An interesting hypothesis stems from the observation that older organisms tend to develop a pro-inflammatory status that is characterized by higher levels of pro-inflammatory markers in cells and tissues, a condition often named inflammageing, a term first coined in 2000 by Claudio Franceschi. Strong evidence indicates that inflammageing is a risk factor for cardiovascular disease, in addition to many age-associated chronic diseases and other adverse health outcomes. Whether inflammageing contributes causally to CVD and other comorbid conditions or is instead a non-causal marker of some other underlying mechanism is still debated. Other than calorie restriction and physical activity, treatment options for inflammageing rely on small molecules or antibodies that interfere with inflammatory mediators or their biological targets rather than targeting the underlying causes, resulting in highly heterogeneous efficacy. In this review, we summarize the current understanding of inflammageing. We explore risk factors and speculate on potential causes. We look at possible roles of inflammageing in CVD and other conditions that are highly prevalent and often coexist with CVD in older adults. We report on findings from intervention studies aimed at modulating inflammation in different diseases, and in particular whether these interventions prevent or attenuate the clinical course of CVD. We continue by examining the role of inflammation in conditions that are typical of aging and often comorbid with CVD, such as multimorbidity, sarcopenia, and frailty. Finally, we identify gaps in our knowledge and suggest priorities for future research. The author states that is there an underlying symptom of inflammation, or is the dysregulation of the immune system that comes with age the cause? That question is unanswered. Risk factors and causes of inflammageing. Aging is associated with immune dysregulation, of which the most evident characteristics are high blood levels of pro-inflammatory immunogenic stimulations. The pro-inflammatory state is characterized by high circulating levels of pro-inflammatory markers, including IL-1, IL-1 receptor antagonist protein, IR1RN, IL-6, IL-8, IL-13, and IL-18, C-reactive protein, IFN alpha, IFN beta, transforming growth factor beta, tumor necrosis factor, and its soluble receptors, TNF receptor superfamily members 1A and 1B, and serum amyloid A. At this time, a comprehensive list of pro-inflammatory markers that are associated with aging have not been compiled, owing to the difficulty of applying high-sensitivity discovery proteomics in plasma and serum. High levels of age-associated pro-inflammatory markers are detected in the majority of older individuals, even in the absence of risk factors and clinically active diseases. Despite its fundamental physiological role as a defense mechanism against infections or extraneous molecules, when inflammation becomes sustained and prolonged, it becomes detrimental to health. According to the antagonistic pleiotropy theory of aging, inflammation might have been evolutionarily selected because of its beneficial effects early in life and in adulthood, although it becomes detrimental in old age when the effect of natural selection is no longer active. Epidemiological studies that have found that inflammation is a risk factor for CVD, cancer, chronic kidney disease, dementia, and depression, as well as for global indicators of poor health status such as multimorbidity, mobility, disability, and disability in activities of daily living, sarcopenia, frailty, and premature death. On the basis of these findings, many researchers have proposed that inflammation is a marker of accelerated aging and should be considered to be one of the pillars of the biology of aging. The root causes of inflammaging are poorly understood, as are the mechanisms that connect inflammaging with CVD and with many other health outcomes. A critical question is whether inflammation directly causes the associated pathology or is instead a biomarker for the rate of biological aging. The answer to this question might depend on the age of the patients and whether we consider CVD by itself or CVD in the context of associated multimorbidity, impairments, and disability. The underlying cause of inflammation should then be mediated or, if it's possible, to know the cause of that inflammation. Genetic susceptibility. Studies in large population have identified a multitude of genetic variants that affect blood levels of inflammatory mediators. We focus on associations that have been confirmed by multiple studies and are functionally relevant. Examining common variants like ILIRN gene revealed that the RS4251961 minor allele is associated with a lowered serum level of IL-1RN, and that the RS579543 single nucleotide polymorphism is also independently associated with IL-1RN levels, whereas the IL-1RN 1018 haplotype correlates with higher concentration of IL-1 beta and IFN gamma. These findings have been confirmed in 3 independent cohorts, and further research has been demonstrated that these factors affect the pathophysiology of human infections and the risk of developing insulin resistance and knee osteoarthritis. A SNP in the promoter region of IL-6 at position 174G greater than C magnifies IL-6 production in response to inflammatory stimuli, but this SMP has been associated inconsistently with baseline IL-6 levels. Carriers of the 174G greater than C mutation have an increased risk of developing various major diseases, including Alzheimer's disease, cardiovascular disease, non-insulin dependent diabetes milieu, bone frailty, and systemic onset juvenile chronic arthritis. A genomic-wide association study comparing greater than 2,000 Chinese centenarians to middle-age controls found that the SMP-RS2069837 in IL-6 was significantly associated with extreme longevity, confirming the role of IL-6 in conditioning morbidity and mortality, especially in old age. Confirming the role of IL-6 in health in a large Mendelian randomization analysis, the IL-6R SMP RS7529229, marking a non-synonymous IL-6R variant, was associated with increased circulating IL-6 levels. Variants in the IL-6R gene have been found to be associated with increased risk of coronary artery disease, rheumatoid arthritis, atrial fibrillation, and abdominal aortic aneurysm, and with increased susceptibility to asthma, type 1 diabetes, and depression. Multiple SMPs in the CRP gene are associated with higher CRP levels and an increased risk of myocardial infarction and CVD-related death. How could that be causing all of that? These data indicate that genetic variability affects the plasma levels of several inflammatory markers and through this mechanism increase the risk of many apparently uncorrelated diseases. Therefore, the cumulative effect of these genetic polymorphisms might be a risk factor for multimorbidity and frailty. Although this hypothesis has never been tested, a gene expression study conducted on whole blood RNA samples from a large population cohort in Europe and the USA revealed that immune response and inflammation were the most highly upregulated pathways associated with aging. A few gene transcripts mediate the age IL-6 association, among which the largest affected transcript, SLC4A10 mRNA encoding the sodium-driven chloride bicarbonate exchanger, explains as much as 19% of this association. Interestingly, this study did not detect the age-related increase in IL-6 mRNA transcript levels, suggesting that the overproduction of circulating proteins occurs in peripheral tissues rather than in blood cells. This is the second time I've heard of this sodium-driven chloride bicarbonate exchanger. Accumulating evidence shows that cellular changes that contribute to inflammageing are mediated by microRNAs, which are non-coding, single-stranded RNAs spanning 17 to 25 nucleotides that generally modulate protein expression programs by interacting with mRNAs that share partial complementarity, thereby reducing mRNA stability and or translation. Studies have shown age-related differences in the abundance of specific miRNAs in circulating cells, plasma and whole blood from older compared with younger individuals. Findings from these studies are inconsistent, possibly owing to difference in sample size, age composition, and health status of the examined individuals, and because miRNA detection methods vary widely in specificity, accuracy, and sensitivity. In addition, given that miRNAs mostly function as intracellular modulators of mRNAs, their concentration in whole blood might be a poor indicator of their physiological effects. Nonetheless, MIR25 3P, MIR92A 3P, MIR93 5P, MIR 101 3P, MIR 106B 5P, MIR 142 5P, MIR 151A 3P, and MIR 181A 5P tend to be underrepresented, whereas MIR 21 5P and MIR 1263P are overexpressed, overrepresented in older ages. Age-related changes in miRNAs have been suggested to contribute to inflammageing. For example, MIR 1263P inhibits endothelial inflammation, and low levels of MIR 1263P were found in patients with CVD and diabetes, whereas MIR 21 5P levels are correlated negatively with CRP and fibrogen levels, and MIR 21 5P levels are higher in patients with CVD than age-matched controls. Other miRNAs such as MIR 146 and MIR 155 might also have a role in inflammaging by affecting cellular senescence or modulating immune responses. Although these activities might not be reflected by changes in miRNA concentration, or these miRNAs might be detected only in exosomes or other structures carrying miRNAs, overall, the contribution of miRNAs to inflammaging is an active area of investigation with high translational potential. Visceral obesity. Epidemiological studies provide some information about the origin of inflammaging. Obesity, particularly central obesity, is strongly associated with a pro-inflammatory state. Adipose sites in abdominal, intramuscular, liver, and pericardial fat can produce pro-inflammatory and chemostatic compounds such as IL-6, IL-1 beta TNF, and CC-motif chemokine 2, as well as hormones that modulate inflammation, such as adiponectin and leptin. The visceral fat tissue of obese individuals is infiltrated by T lymphocytes, macrophages, and monocytes. T lymphocytes secrete IFN gamma, which stimulates the production of several chemokines from adipocytes, including CCL2, CCL5, CXC-motif chemokine 9, and CXCL10, which further amplify tissue T-cell migration. The number of B lymphocytes and macrophages in visceral adipose tissue from obese individuals is also increased and is correlated with BMI. Studies with animal models suggest that a specific subset of B cells expressing the TNF ligand superfamily member 9 and producing TNF and IFN gamma and granzyme B is increased in the peritoneal cavity during aging. Cytokines released by B cells contribute to the phenotypic switch of adipocytes in the visceral cavity, causing them to release adipokines, other pro-inflammatory markers, and cell debris. Activated monocytes that give rise to M1 and M2 macrophages produce even more inflammatory compounds than probably appear in the circulation. Weight loss through induced dietary intake and possibly bariatric surgery is associated with reduction in primary pro-inflammatory markers, in part owing to normalized expression of inflammation-related genes in white adipose tissue and to downregulation of the NLRP3 inflammasome. In addition, calorie restriction in humans is associated with a substantial reduction in pro-inflammatory markers in the blood. Weight loss combined with exercise improves functional status and reduces some of the features of frailty in obese older individuals, improves the cardiovascular risk profile, and reduces the risk of CVD. Although whether these beneficial effects are caused by reduced inflammation remains unclear. Microbia and gut permeability. A new hypothesis on the origin of inflammation highlights changes that occur in the gut microbia, with aging as well as age-associated changes in gut permeability. Despite large variability in the gut microbia found in different population, geographic regions, and settings, evidence suggests that aging is associated with a reduction in beneficial commensal microorganisms, such as Cryptococcus, Faecalibacterium, and Lactobacillus, as well as a decrease in the Firmicutes bacteroidetes ratio. The disappearance of these microorganisms is important because they normally counteract the expression of pathogenic microbial communities, while also maintaining intestinal barrier integrity by fermenting starches and dietary fibers and producing mucus and lipid metabolites, such as short-chain fatty acids, primarily acetate, propionate, and butyrate. As beneficial intestinal bacteria decrease in abundance with aging, other bacteria increase in relative abundance, including symbiotic bacteria that can become pathogenic under inflamed conditions, often termed pathobionts. This category of microorganisms is enriched in the gut of older adults and is primarily dominated by facultative amoebas, such as Fusobacterium and Streptococcus, a state that have been associated with increased levels of inflammatory cytokines in plasma. Increased gut dysbiosis has been postulated to increase mucosal barrier permeability, thereby allowing bacteria and their products, including pathogen-associated molecular patterns, damage-associated molecular patterns, and microbial-associated molecular patterns, into the circulatory system. Together, these factors contribute to a chronic pro-inflammatory state. The theory is suggested by studies of animal models, but no definitive evidence exists of increased gut permeability and leakage of pro-inflammatory products in older individuals who are free from overt inflammatory disease. Dysbiosis seems to be more severe in conditions in which prevalence increases with aging, such as obesity and type 2 diabetes. Of note, changes in gut microbial composition have been shown to be associated with increased frailty, which could be owing to gut dysbiosis-induced inflammation. Centenarians, who can be considered extreme examples of healthy aging, have an enrichment of Akkermansia, Bifidobacterium, and Creston senalicae in their intestinal flora, which promote positive immune function, have anti-inflammatory activity, diminish the effects of obesity, and contribute to metabolic homeostasis. Consistent with the notion that changes in the gut microbial composition can affect healthy aging, calorie restriction, the most powerful strategy to increase longevity in animal models, causes changes in microbial composition, decreases inflammation, and improves gut barrier integrity. A healthy intestinal tract flora can theoretically be promoted by the administration of probiotics, prebiotics, or a combination of the two. Some studies have shown that this strategy can reduce systemic inflammation and progression of central obesity, but more research in this area is needed to substantiate this initial evidence and to assess whether the reduction of inflammation owing to microbial changes has beneficial effect on health. So microbia and gut permeability, we are looking at, in both cases, identifying the proper function and trying to implement that function in the human being, both in the immune system and now in the microbia. Those recipes, those and the activities that labs can do with that information in the production of products is key to fulfilling these ideas. Cellular senescence. A number of biological mechanisms that have been identified as the hallmark or pillars of biological aging might account for inflammageing. Paramount among them is the accumulation of senescent cells in multiple tissues. Cellular senescence is generally considered to be a pre-encoded cancer suppressor mechanism characterized by cell cycle arrest, loss of proliferation capacity, global cell enlargement, characteristic misshaped nuclei, presence of chromatin foci with persistent DNA damage response, increased nuclear factor Kb, NF-κB signaling, and resistance to apoptosis. Senescent cells are recognized by specific markers, including cyclin-dependent kinase inhibitor 2A, commonly known as P16, and increased lysosome beta-galactidase activity, although these markers are neither fully sensitive nor specific, and despite intense research, no gold standard biomarker of cellular senescence has been established. Jack and colleagues hypothesized that genetic variants associated with general susceptibility to multiple diseases are enriched in specific areas of the genome. Interestingly, SNPs located with near regulators of senescence and inflammation are particularly associated with diseases of aging, such as cancer, CVD, and type 2 diabetes, and the strongest association was found with the variant in the CDKN2A gene, which encodes the P16 protein that is overexpressed in many forms of senescence. These findings were replicated in a meta-analysis that included 410 genome-wide association studies. In addition, the variant RS28111712 that is close to the CDKN2A gene was associated with poor physical function in two different cohorts. Therefore, senescence seems to be associated with aging, inflammation, CVD, and impaired physical function in older individuals, making cell senescence a strong candidate as a mechanism of inflammageing. Cell senescence can be triggered by many stimuli, including critical telomere shortening, persistent DNA damage, oncogene activation or inactivation, epigenetic alteration, mitochondrial dysfunction, and exposure to DAMPs that are released by stress cells, with some evidence that these phenotypic manifestations induced by different triggers such as heterogeneous. At the core of the replication arrest is increasing levels of cyclin-dependent kinase inhibitors that block the phosphorylation of retinoblastoma-associated protein and initiate cell cycle arrest. In adulthood, activation and retinoblastoma-associated protein can occur either through the cellular tumor antigen p53 that activates cyclin-dependent kinase inhibitor 1, commonly known as p21, or directly through the activation of p16. Theory suggests that senescence is not an acute switch, but instead evolves in stages from a temporary or reversible status to a chronic irreversible condition. Relevant to inflammageing, senescent cells acquire a senescence-associated secretory phenotype that involves the secretion of a wide variety of soluble molecules. The list of these molecules is not comprehensive, and the molecules can vary on the basis of cell type and triggering factors, but usually include interleukins, IL-1 alpha, IL-1 beta, and IL-6, chemokines, IL-8, and growth-regulated alpha protein, growth factors, fibroblast growth factor 2, hepatocyte growth factor, metalloproteinases, interstitial collagenase, also known as MMP1, stromelasine 1, also known as MMP3, and collagenase 3, also known as MMP13, and other insoluble protein and extracellular matrix components. These secretory molecules mainly function in a paracrine fashion and can facilitate the development of cellular senescence in neighboring cells. But some of the soluble mediators are released into the circulation and are likely to contribute to inflammageing. Studies have shown that senescent cells accumulate exponentially with aging in different organs and tissues, both in model organisms and in humans. In humans, the accumulation of senescent markers have been demonstrated in the skin, T lymphocytes, atherosclerotic lesions, insulin-producing beta cells, kidney, endothelium, visceral fat, joint cartilage, cardiac muscle, and many other tissues. Some tissues are likely to have a greater propensity to developing cellular senescence than others, but research in this area is scarce. Of note, senescent T-cell accumulation has been demonstrated in patients with chronic infections such as cytomegalovirus or human immunodeficiency virus infection, which might explain why patients with CMV or HIV infection have chronically elevated levels of pro-inflammatory markers and reduced vaccine efficacy. In mice, the clearance of P16 positive cells extends lifespan and slows the emergence of aging phenotypes and age-related functional deterioration of organs and tissues. The extent to which the burden of senescent cell accumulation in humans is associated with inflammaging and organ damage, and whether a plasma protein signature can be developed that correlates with cell senescence burden, are important areas of investigation. Cellular senescence. When is something like that going to be available? Not in reference to another disease, but in reference of improving the aging phenotype. Impaired recycling and elimination of degraded cellular material. Despite the apparent stability of the human body, a massive turnover of molecules, microorganelles, cells, and cellular components occurs constantly throughout life. A complex and well-regulated molecular machinery constantly surveys cellular components and handles the repair or elimination of biological debris, as well as broken or misplaced fragments. Within cells, worn-out macromolecules and organelles are physiologically recycled by proteasome degradation or autophagy. Extracellular debris is recognized by the immune system through different receptors, including pattern recognition receptors, and is then degraded by engulfment in phagocytic vesicles. Under pathological conditions, molecules are released by stressed cells undergoing necrosis, such as during ischemia, reperfusion, or severe infection. These molecules, called DAMPs, include reactive oxygen species from damaged and unrecycled mitochondria, extracellular nucleotides such as ATP, oxidized cardiolipin, free nuclear and mitochondrial DNA fragments, or histones, high mobility group protein V1, oxidized LDL, amyloid beta, islet amyloid polypeptide, and particulates such as monosodium urate and cholesterol crystals, in addition to many others. If not promptly removed, these molecules accumulate and possibly contribute to inflammageing. Accordingly, inflammageing is proposed to originate from an imbalance between the production and disposal of cellular debris, misfolded proteins, and or misplaced self molecules that develop with age. For example, accumulation of DAMPs is sensed by the NLRP3 inflammasome and causes NLRP3 oligomerization, resulting in caspase-1 dependent secretion of the inflammatory cytokines IL-1 beta and IL-18. In humans, IL-18 blood levels increase with aging. A strong evidence from mouse studies indicate that blockade of the NLRP3 inflammasome extends health span, attenuating multiple age-related degenerate changes that have been linked to inflammaging, including insulin resistance, thymic involution, T-cell senescence, and bone loss, as well as physical and cognitive functional decline. Of note, ROS produced by dysfunctional mitochondria can also trigger an inflammatory response by activating NF-κB signaling pathway. Quite a complex chapter. Intrinsic defects in immune cells and chronic infections. Intrinsic defect in immune cells and chronic infections. Studies conducted in isolated immune cells, mostly lymphocytes, suggest that an intrinsic defect in immune cells also contributes to inflammaging. For example, gene expression studies show that CD4 plus lymphocytes from older individuals have higher intrinsic activation of the NF-κB pathways than those from younger individuals. After stimulation with anti-CD3, the production of pro-inflammatory cytokines in vitro is lower in cells from older individuals than in cells from younger individuals, a phenomenon that might be related to altered metabolic activity. However, because these studies have been performed only in small population, their relevance to inflammaging is unknown. Subclinical and clinical evident chronic infections can chronically stimulate immune function and result in changes in levels of inflammatory markers that are indistinguishable from those of the inflammaging signature. Particularly relevant for inflammaging are human CMV and HIV infections. Human CMV infection is herpesvirus present in a latent state in more than half of the adult population, where intermittent transcription episodes cause antigen reactivation throughout the life course. This situation might explain why the human CMV specific memory T cells can comprise up to 50% of the total memory T cell compartment in older individuals, which leads to the hypothesis that persistent human CMV infection has a role in immunosenescence and inflammaging. However, evidence to support this hypothesis remains controversial. Some studies have found that human CMV infection in older individuals is associated with increased cardiovascular and all-cause mortality, negative immune risk profile, inflammaging, and lower antibody responses to influenza. However, evidence that the association between CMV infection and CVD and mortality is mediated by inflammageing is scant at best. The theoretical CMV-associated impaired capacity to control heterologous infections in old age and the association with high circulating levels of pro-inflammatory cytokines have also been challenged. Ultimately, whether human CMV infections cause accelerated immune senescence is controversial. In the era of highly active antiretroviral therapy, patients with HIV infection have a life expectancy that is on average only slightly lower than the general population. However, this therapy does not protect patients from the persistent immune activation, chronic inflammation, and excess risk of developing CVD and frailty. Chronic inflammation in HIV is mediated by depletion of memory CD41 T cells, resulting in increased permeability in the gut epithelium and translocation of microbial products into the circulation, which causes inflammation. Patients with HIV are also affected by antiretroviral associated lipodystrophy and visceral obesity that can further contribute to inflammation and cause insulin resistance. Finally, chronic infections such as oral infection, asymptomatic chronic infection in the urinary and biliary tracts, and hidden intestinal infections are associated with the release of PAMPs into the circulation, which elicits a persistent inflammatory state. Treatment of these infections can reduce inflammation and potentially has many long-term beneficial effects beyond immediate local resolution of symptoms. As explained above, the possible causes of inflammageing are numerous and very heterogeneous. These different mechanisms are likely to be additive and interconnected, acting in different combinations and with different relevance in selected individuals. Therefore, effectively reducing inflammation without weakening the surveillance and defensive functions of the immune system requires individualized approaches as well as an accurate diagnosis of the underlying causes of inflammation. So, in this image, they have listed all of the potential causes of inflammageing, starting with genetic predisposition, microRNAs, adipose pro-inflammatory phenotype, listing the interleukins and the components in each, visceral fat tissue infiltrated by B cells, T cells, and macrophages, also listing the offending things, visceral obesity playing a major role, mitochondrial dysfunction, oxidative stress, epigenetic alterations, paracrine senescence, cellular senescence, changes in gut microbiome, chronic infection, intrinsic immune cell defects. Potential causes of inflammation. Several genetic variants associated with high levels of inflammatory markers or increased response to inflammatory stimuli have been identified. The most relevant factors are indicated in parentheses. In central obesity, visceral fat tissue is infiltrated by T cells, macrophages, and monocytes. T cells secrete IFN gamma, which stimulates the production of serochematines by adipocytes, including CC motifs chemokine 2, and a whole bunch of others, which further amplify tissue T cell infiltration. The number of B cells and macrophages in visceral adipose tissue from obese individuals is also increased and is correlated with BMI, body mass index, a specific subset of B cells expressed in the tumor necrosis factor, superfamily ligand, superfamily member 9, and producing TNF, IFN gamma. and granzyme B accumulates in the abdominal cavity of older individuals. Cytokines released by B cells contribute to the phenotypic change of adipocytes in the visceral cavity, causing them to release adipokines, other pro-inflammatory factors, and cell debris. Activated monocytes that give rise to M1 and M2 macrophages produce even more inflammatory compounds, damage mitochondria that cannot be repaired by repeated cycles of fission and fusion and are not recycled owing to defective autophagy, release damaged associated molecular patterns, DAMPs, and trigger the NLRP3 inflammasome and lead to caspase-1 dependent production of IL-1 beta and IL-18. Oxidative stress is one of the possible triggers of cell senescence, which can be induced by several other stresses, including the epigenetic alterations. Senescent cells, through the senescence-associated secretory phenotype, secrete large quantities of cytokines, chemokines, and other molecules, locally triggering more cell senescence, paracrine senescence, and contribute to inflammageing. Studies have emphasized the role of age-related changes in the microbiome and increases in the gut mucosa permeability that lead to bacterial product released into the blood and stimulate an inflammatory response in part through the NLRP3 inflammasome. In addition, part of inflammageing is probably caused by chronic infections. For example, human immunodeficiency virus or human cytomegalovirus infection, and intrinsic defensive mechanisms in immune cells that might involve metabolic stress as well as age-related changes in microRNA transcription. Of note, other important triggers of cell senescence, such as genomic instability, the activation of oncogenes, and the inhibition of tumor suppressor genes, are not shown in the figure but might be part of the same mechanism. What if your doctor read that out to you? You'd just be like, kill me now, doc. Doc, just kill me. Nothing works. Consequences of inflammageing for CVD. Although strong epidemiological evidence indicates that inflammation is a powerful risk factor for CVD, non-cardiovascular comorbidities and conditions that are often associated with CVD, as well as with frailty, disability, and morbidity, mortality in older individuals, and the mechanisms that underlie these associations have only just begun to be elucidated. Controversy exists on whether high levels of pro-inflammatory compounds in the circulation and tissues causally contribute to associated pathological conditions, or whether inflammation is a reactive marker of underlying pathology. These two mechanisms are not mutually exclusive. For example, early damage that occurs during vascular endothelial cell inflammation participates in the pathogenesis of atherosclerotic plaques, whereas atherosclerosis itself produces antigens that trigger and sustain an inflammatory response, and senescent cells are found often in large quantities in atherosclerotic plaques. Therefore, multiple mechanisms amplify the role of inflammation in atherogenesis. In this section of the review, we summarize the available evidence to suggest that chronic inflammation is both a risk factor and a pathogenic mechanism in CVD. Moreover, because inflammation also contributes to the pathogenesis of other chronic non-CVDs, such as anemia, cancer, type 2 diabetes, and dementia, osteoporosis, sarcopenia, chronic kidney disease, and depression, CVDs in old age often develop in the context of multimorbidity and frailty. Epidemiological studies have produced insufficient evidence to demonstrate whether inflammation occurs in response to underlying disease pathologies or whether inflammation itself contributes to the disease initiation and progression. To address this issue, we combine observational evidence with results from randomized controlled trials and tested the efficacy of anti-inflammatory drugs in preventing or controlling CVD clinical manifestations. Figure 2 shows us inflammaging is a risk factor for multiple chronic diseases. So you have inflammageing, cardiovascular disease, type 2 diabetes, mellitus, chronic kidney disease, cancer, depression, dementia, osteoporosis, sarcopenia, anemia, multimorbidity, physical disability, cognitive disability, frailty, premature mortality. Inflammaging as a risk factor for multiple chronic diseases. Inflammageing, defined as an age-related increase in the level of pro-inflammatory markers in the blood and tissues, is a strong risk factor for multiple diseases that are highly prevalent and frequent causes of disability in elderly individuals but are pathophysiologically uncorrelated. Mild chronic inflammation is generally considered to be a biomarker of accelerated biological aging, or one of the mechanisms by which the aging process is associated with increased global susceptibility to all diseases. Cardiovascular diseases, chronic kidney disease, cancer, depression, dementia, osteoporosis, sarcopenia, and anemia are shown in the figure for examples because extensive evidence indicates that inflammation contributes to the development of these diseases in old age. But the list is far from exhaustive. Concordant with this view, elevated blood levels and pro-inflammatory markers such as IL-6 are a powerful risk factor for multimorbidity, the number of coexisting diseases, and predict future rates of change in multimorbidity. Unsurprisingly, inflammageing is also a strong risk factor for typical geriatric conditions, such as physical and cognitive disability, frailty, and premature death. Although this effect is primarily mediated by multimorbidity, evidence also indicated that inflammation interferes with the maintenance and repair that constantly occur in all tissues, leading to the accumulation of damage that contributes to aging. Table 1 shows us clinical trials of anti-inflammatory drugs in chronic inflammatory diseases. So the strategy here is to map this system out and then use drugs to mediate the immune system artificially. Determining those underlying conditions is a whole different, whole new higher level of complexity. Resolving those underlying issues is an even greater level of complexity. Atherosclerosis. Atherosclerosis originates from damaged endothelium that allows the accumulation of cholesterol containing LDL particles in the arterial wall that tend to be oxidized, which triggers an inflammatory response that fails to resolve. Activation of both innate and adaptive immunity actively contributes to the initiation and progression of atherogenesis. From early endothelial dysfunction to the development of acute thrombotic complications triggered by plaque rupture or erosion. Monocytes that migrate into the intima of the arterial wall differentiate into macrophages and then transform into foam cells in the lipid necrotic core of the atheroma. Cholesterol crystals and other damps present in the atherosclerotic lesion activate the inflammasomes within macrophages, leading to the release of IL-1 beta, IL-18, and other pro-inflammatory cytokines. There are chemotactic and other inflammatory cells that are chemotactic for other inflammatory cells, including T cells and B cells, which are major drivers of atherosclerosis. Late atherosclerosis is characterized by massive cell apoptosis and accumulation of cells with senescent features, which support a pro-inflammatory status and lead to the formation of a necrotic core that ultimately causes frailty and rupture of the plaque, formation of thrombosis, and acute vascular occlusion. Cells in advanced atherosclerotic plaques often show markers of senescence such as P16, Link4A, and tumor suppressor ARF, commonly known as P14 ARF in humans and P19 ARF in mice, and express a SASP that further fuels inflammation, while producing metalloproteinases that degrade the extracellular matrix, further destabilizing the atherosclerotic plaque. In turn, the degradation of the extracellular matrix induces the proliferation and phenotypic shift of vascular smooth muscle cells that migrate from the medial layer, and by synthesizing new extracellular matrix, builds a fibrous caps that stabilizes atherosclerotic lesions. However, in an inflammatory environment, vascular smooth muscle cells undergo extensive DNA damage and extensive telomere shortening, develop markers of senescence, and might undergo loss of proliferative capacity or even apoptosis. In addition, the production of metalloproteinases from senescent cells can further weaken the fibrous cap. Therefore, major mechanisms of plaque stabilization are impaired, and additional antigens might be uncovered that further amplify the inflammatory response. Preclinical studies have shown that activated subtypes of T and B lymphocytes in plaques contribute to plaque instability, leading to an increase in the risk of cardiovascular disease. miRNAs have emerged as an important regulators of cellular adhesion, proliferation, lipid homeostasis, and inflammatory cytokine synthesis, potentially affecting the balance between atherosclerotic plaque progression and regression, although their mechanism of action and relationship with inflammaging is not fully clarified. Although the detailed mechanisms that affect the genesis and progression of atherosclerotics are far from being fully understood, evidence is accumulating that inflammation is a major contributor, acting through multiple mechanisms, including a vicious cycle that accelerates clinical progression. Consistent with the view, longitudinal studies demonstrate that high blood levels of pro-inflammatory markers, including high sensitivity CRP assay and IL-6, predict the risk of cardiovascular disease in both middle-aged and older adults, independent of other CVD risk factors. Moreover, statin therapy with rosuvastatin reduces the incidence of major cardiovascular events in healthy individuals who are free from hyperlipidemia but who have elevated high sensitivity CRP levels. Although studies in endothelial cells suggest that CRP directly contributes to CVD by increasing oxidative stress, although studies in endothelial cells suggest that CRP directly contributes to CVD by increasing oxidative stress, other mechanistic studies and Mendelian randomization analysis in large populations suggests that CRP is a predictive biomarker that is not causally related to atherothrombosis. By contrast, IL-6 and IL-1 contribute to atherosclerosis and should be considered to be therapeutic targets. Mendelian randomization studies have shown that polymorphisms that affect IL-6 signaling are associated with lower lifetime risk of cardiovascular disease. In the MEASURE trial, the IL-6 receptor blocker tocilizumab increased the concentration of HDL particles in patients with rheumatoid arthritis compared with placebo. Despite an increased multi-center Entracti trial compared with the cardiovascular safety profile of tocilizumab to that of the TNF inhibitor etanercept in greater than 3,000 patients with moderate to severe rheumatoid arthritis, but the final results are not yet published. In addition, because IL-1 beta production is a secondary effect of NLRP3 inflammasome activation, which is induced by cholesterol crystals and other DAMPs. The IL-1 beta signaling pathway has been suggested to be a promising target for atherosclerosis protection. New compounds that interfere with IL-1 and IL-6 signaling are under investigation. The CANTOS trials have revealed that anti-inflammatory therapy with canakinumab, a human monoclonal anti-IL-1 beta antibody, significantly reduced recurrent cardiovascular events in greater than 10,000 stable patients who had residual inflammation after myocardial infarction. Independent and lowered lipid levels. The ongoing CIRT trial in testing the hypothesis that low-dose methotrexate, a drug that suppresses IL-1 beta production by mononuclear cells in addition to other function, reduces major vascular events in patients with previous myocardial infarction and either type 2 diabetes or metabolic syndrome. In a small pilot study, the LODOCO trial, anti-inflammatory treatment with colchicine seemed to be effective for secondary prevention of CVD. Larger RCTs, such as the ongoing LODOCO-2 trial and COLCOT trials, are needed to confirm these findings. Type 2 diabetes. The focus of this review is on inflammageing, conceptualized as a shared risk factor and pathophysiological mechanism between CVD and frailty. However, it is important to note that inflammation is associated with the risk of clinical evolution of non-CVD related disease and accelerated decline of physical function. This concept is clearly exemplified by the close connection between inflammation, CVD, and type 2 diabetes. Type 2 diabetes is a strong risk factor for CVD, and both CVD mortality and the effect of diabetes on the risk of CVD increase sharply with older age and frailty status. Strong evidence indicates that insulin resistance and lipotoxicity cause the production of inflammatory mediators that cause neutrophil infiltration, macrophage proliferation, and smooth muscle and endothelial cell activation, which accelerates atherogenesis. Excessive oxidative stress causes endothelial dysfunction that enables permeation, trapping, and physicochemical modification of circulating lipoprotein particles in the subendothelial space. Telomeres are on average shorter, and the number of cells positive for senescent biomarkers is higher in arteries from patients with diabetes than in individuals without diabetes. And this finding might be one of the mechanisms for the increased inflammation and accelerated atherosclerosis in diabetes. Overproduction of angiotensin II amplifies chronic inflammation and can cause mitochondrial dysfunction. At the same time, inflammation is a risk factor for the development of diabetes and its complications, and these associations are not accounted for by body composition parameters. Treating inflammation in non-CVDs. Of note, a causal role of inflammation in CVD pathogenesis is also suggested by clinical trials that used an anti-inflammatory intervention and treatment for overt non-cardiovascular inflammatory diseases. For example, treatment with TNF inhibitors in rheumatoid arthritis. An overt inflammatory disease is associated with a decreased risk of cardiovascular events. Treatment with TNF inhibitors in psoriasis is also associated with decreased incidence of major adverse cardiac events. However, anti-inflammatory treatment does not always yield beneficial results. For example, in patients with congestive heart failure, the levels of pro-inflammatory cytokines, especially TNF, IL-6 and IL-1, are markedly elevated, and the TNF level is a negative prognostic factor. However, clinical trials with the TNF inhibitor etanercept yielded no beneficial reductions in mortality or hospitalization due to the congestive heart failure, whereas high doses of infliximab, a TNF agonist, do not improve and even worsen moderate to severe congestive heart failure. Multimorbidity and frailty. The important role of inflammation in CVD, in particular in atherosclerosis, together with the observation that the pro-inflammatory state typical of aging is a strong risk factor for many age-related chronic diseases, explains why CVD in older individuals often precedes, follows, or develops in the context of multimorbidity and frailty. Patients with CVD tend to have greater multimorbidity than individuals who are free from CVD. Diseases most often associated with multimorbidity and diabetes, chronic kidney disease, anemia, chronic pulmonary disease, depression, and dementia, which all involve inflammageing as an important risk factor. The presence of comorbid diseases is well established to affect both the response to treatment and the prognosis for hard clinical outcomes, such as cardiovascular and all-cause mortality, as well as hospitalization and healthcare utilization. However, limited data are available on whether CVD comorbidities affect non-traditional outcomes that are still very important for geriatric patients, such as symptom burden, functional capacity, and self-rated health. Whether these important non-traditional outcomes respond to anti-inflammatory treatment is also unknown, because this information is not commonly collected in most RCTs. The resulting syndromes present clinical challenges whose complexity is often ignored in clinical practice guidelines for single diseases, which are based on randomized clinical trials in which patients with multimorbidities are underrepresented, including most of the trials cited above that targeted inflammation. The degree of clinical complexity is even higher when the comorbid medical condition is frailty. Age-associated frailty is a medical syndrome characterized by the morphological and physiological changes across multiple systems and organs, resulting in a progressive loss of internal homeostasis, reduced physiological reserves, loss of function, reduced resilience, and increased vulnerability to internal and external stresses. We address the general pathophysiology of frailty later in this review. Here we limit the discussion to the effect of frailty that emerges in patients with CVD. The prevalence of frailty in older individuals with CVD rises progressively from subclinical CVD to heart failure to overt acute syndrome to cardiac surgery, when depending on the procedure, the rate of frailty can be greater than 60%. Strong evidence from multiple large observational studies indicates that the presence of CVD is a risk factor for frailty, and that patients with frailty are more likely to develop CVD than those who are not frail. This observation is not surprising because inflammation, insulin resistance, and coagulation problems have been identified in cardinal factors in the pathophysiology of frailty. Therefore, CVD and frailty can be viewed as diseases arising from similar causal mechanisms, mutually accelerating their clinical course by vicious cycles that amplify inflammation, insulin resistance, and other still unknown mechanisms, thereby synergistically contributing to adverse health outcomes. In accordance with this theory, independent of age and other risk factors, frailty in patients with CVD is associated with a twofold increase in the risk of death. We have previously proposed that a pro-inflammatory state might be caused by most of the described putative biological mechanisms of aging, such as telomere shortening, cell senescence, mitochondrial dysfunction, altered nutrient sensing, and epigenetic alterations. Therefore, the coexistence of CVD, diabetes, and frailties might be just one example of a general phenomenon that involves multiple diseases, as exemplified by the following observations. Low-grade chronic inflammation is a primary contributor to the onset and progression of chronic kidney failure, chronic kidney disease. Inflammation is a causal factor for cancer initiation, promotion, malignancy, and metastatic dissemination. Depression is characterized by increased levels of pro-inflammatory cytokines and acute phase proteins in both peripheral blood and cerebral spinal fluid. Inflammatory diseases and high levels of pro-inflammatory biomarkers in the blood increase the risk of depression. Inflammation has a central role in the age-related neurodegeneration and in neurodegenerative diseases, such as Alzheimer's disease. These studies support the hypothesis that neuroinflammatory changes are important pathological components of Alzheimer's disease and other neurodegenerative diseases, highlighting the potential of clinical importance of cytokines in neurogenesis. Interestingly, most genetic variants associated with late-onset Alzheimer's disease are within immunity-related genes. Inflammation and age-related frailty. The collective evidence suggests that chronic inflammation is a risk factor across multiple diseases, some of which are traditionally viewed as pathophysiologically unrelated, such as CVD, diabetes, chronic kidney disease, cancer, depression, and dementia. In addition, higher levels of inflammatory markers in blood are associated with a greater loss of muscle mass, strength, accelerated loss of mobility, lower extremity performance, and physical activity, and depression in older individuals, all of which are essential elements for defining frailty on the basis of the criteria most often used in the literature. From this perspective, inflammageing could act as a focal point for aging mechanisms that are associated with increased susceptibility to stresses and impaired functional reserves. Consistent with this observation, both higher baseline levels and increasing accumulation rates of IL-6 predict accelerated longitudinal accumulation of multiple chronic diseases in older individuals. In addition, inflammation contributes to accelerated aging in individuals with multimorbidity and partially mediates the association between multimorbidity and functional limitation and disability. Not surprisingly, most patients with frailty have chronic inflammation, especially those who are affected by sarcopenia, which is defined as a reduction in muscle strength and mass that is abnormally severe for an individual's age. A variety of hypotheses have been proposed to explain the link between inflammation and sarcopenia and frailty. Interestingly, some of these mechanisms are shared with the pathogenesis of CVD. Inflammation is associated with reduced synthesis and activity of insulin-like growth factor 1, a growth factor that is essential for muscle regeneration and maintenance of muscle integrity, and that is protective against plaque instability and atherosclerosis. In vitro studies have shown that IL-1 alpha, IL-6 TNF inhibit IGF-1 mediated anabolism, and that IL-6 reduces the production of IGF-1 and IGF-1 protein 3. In observational studies, higher level of IL-6 and low levels of IGF-1 synergistically correlate with lower muscle strength and power, effectively predicting progressive disability and death. Inflammation impairs endothelial reactivity and muscle perfusion, interfering with the uptake of long-branched chain amino acids that are essential for muscle energetics and protein anabolism. Dysfunctional mitochondria that are not recycled owing to defective mitophagy produce ROS that stimulate the production of pro-inflammatory cytokines and catabolism via increased NFKB-dependent protein ubiquitination and proteasome degradation. Senescent cells that produce inflammatory mediators might also have a role in the pathogenesis of sarcopenia. One studies quantified senescent P16 expression cells in thigh intramuscular adipose tissue from older women, revealing that senescent cell burden was associated with grip strength, walking speed, and self-perceived mobility. Moreover, inflammation impairs satellite cell regenerative function. Of note, the emergence of senescence traits in vascular smooth muscle cells have been implicated in the initiation and progression of CVD, specifically atherosclerosis, again suggesting that atherosclerosis and the resulting CVD is a syndrome of accelerated aging. Both aerobic and resistance exercise, as well as dietary supplementation of amino acids or protein, vitamin D, and polyunsaturated fatty acids, have been associated with protection against age-associated sarcopenia, possibly because of their anti-inflammatory and antioxidant properties. In observational studies, adherence to the Mediterranean diet was the only behavioral factor consistently associated with a lower risk of frailty, which might be a result of the anti-inflammatory properties inherent to the diet. Underlying the relationship between CVD and frailty, the Mediterranean diet is also one of the few behavioral interventions that, in both observational studies and clinical trials, was associated with lower cardiovascular morbidity and mortality. Aspirin, a potent anti-inflammatory module, is effective in the treatment of acute myocardial infarction and in secondary prevention of CVD. Some evidence indicates that aspirin might be effective in primary prevention of myocardial infarction, at least in high-risk groups. Interestingly, chronic use of NSAIDs is associated with a lower risk of sarcopenia in community-dwelling individuals aged greater than 80 years. Metformin, an anti-diabetic drug that counteracts inflammation and insulin resistance, has been suggested to prevent frailty and attenuate its progression. In a large observational study conducted in the US veterans with type 2 diabetes and stratified according to the baseline risk, treatment with metformin reduced the risk of multiple age-related diseases, including CVD, cancer, depression, and frailty-related diseases, and RCTs conducted in Indonesia revealed that metformin improves gait speed but not hand grip strength in non-diabetic pre-frail older adults. The trial is currently ongoing at the University of Texas Health Science Center at San Antonio, Texas, aimed at examining whether metformin prevents frailty development in older adults with impaired glucose tolerance. So would an androgen and exercise? Like, why would metformin be the go-to molecule for that? You would go for a mild androgen and also exercise, and that would produce a greater paracrine effect and stave off sarcopenia and frailty. Metformin has no androgenic effect. How is it going to? The evidence reported also suggests that CVD, multimorbidity, frailty, and perhaps other chronic diseases have inflammageing as a common root cause. Unfortunately, although strong evidence shows that targeting inflammation can reduce the risk of CVD, no definitive evidence exists that reducing inflammation can prevent or modify the progression of multimorbidity with frailty or sarcopenia. In part, this situation is because of the lack of adequately sized RCTs to test this hypothesis, and because RCTs have tested the effectiveness of anti-inflammatory treatments for cardiovascular prevention did not collect data on multimorbidity, frailty, or disability. These issues should be considered a priority in setting the future research agenda. The Energize trial is an ongoing multi-center double-blind placebo-controlled randomized pilot study enrolling older men and women aged 70 plus who have high levels of IL-6 and impaired physical function to test whether low-satin omega-3 fish oil or a combination of the two reduce plasma IL-6 levels compared with placebo. Interestingly, results from the Kratos trial demonstrated administration of allogenic human mesenchymal stem cell improves measures of lower extremity performance and reduces inflammatory biomarkers in age-related frailty. By contrast, despite their anti-inflammatory efforts, statin use in the Women's Health Initiative survey had no significant effect on risk of frailty. So it says that mesenchymal stem cells improves measures of lower extremity performance and reduces inflammatory biomarkers in age-related frailty. That would be interesting because if you're sending in a lot of repair modules and upregulating a lot of the repair systems with the mesenchymal stem cells and some kind of lysates, you might find a more permanent resolution to the inflammatory. Inflammageing is a pillar of geroscience. Many interventions that increase longevity in animal models cause a reduction in inflammatory markers. For example, caloric restriction is the most powerful life extension intervention in most animal models and is associated with the reduced inflammatory biomarkers. Mechanisms by which caloric restriction reduces chronic inflammation include diminished ROS production and consequent downregulation of necrosis factor Kb, induced transcription of pro-inflammatory genes in multiple tissues. Of note, dietary restriction significantly reduces the risk of CVD in humans and in animal models. Dietary restriction is associated with numerous beneficial changes in arterial walls. Rapamycin, a specific inhibitor mechanistic target of rapamycin, mTOR signaling with many effects including anti-inflammatory activity, has an important role in longevity regulation in both animal and humans, and improves survival of health span in animal models. Aspirin improves lifespan in mice, whereas metformin, which is also known to have direct anti-inflammatory effects beyond its canonical glucose-lowering activity, improves lifespan and health span in animal models. A meta-analysis revealed that metformin reduces all-cause mortality and diseases associated with aging independent of diabetic control in humans. The TAME trial is designed to examine the effect of metformin on delaying the onset of age-related conditions and diseases and its potential use for expanding human health span. Finally, the clearance of senescent cells by either genetic engineering or the administration of senolytic drugs have been associated with the reduced circulating levels of pro-inflammatory markers, increased lifespan, and delayed frailty related to phenotypes in mice. Clinical trials are needed to test the efficacy of these potential treatments in humans. These examples suggest that interventions that target some of the fundamental mechanisms of aging affect the general susceptibility to CVD, as well as other related diseases, and prevent frailty and disability in older individuals. Over the past 3 decades, a wealth of evidence has been gathered that suggests that chronic inflammation is one of these mechanisms. Although this review on the connection between inflammageing CVD and frailty is far from comprehensive, the role of chronic inflammation in health and functional deterioration with aging is clearly emerging. Of course, conceptual problems remain. Throughout this review, we have focused on inflammation as posing a threat to human health over the course of aging. However, inflammation has been evolutionarily selected as a fundamental defensive mechanism that protects organisms from microbial invasion, ensures the integrity of a self-recognized inventory of proteins and other macromolecules, prevents cancer by recognizing and removing cells that present tumor antigens, and have an important role in tissue repair. The benefits of inflammation overcome the risks associated with autoimmune disease and inflammation. As such, inflammation has a positive influence on health when activated transiently, that is, when inflammation deploys quickly and fully armed in response to an adequate stimulation, successfully eliminates the challenge and recedes quickly to a baseline resting state. When inflammation becomes chronic, however, problems arise and deleterious effects emerge, as first described by Rudolf Virchow, 1821-1902. Chronic inflammatory diseases, such as certain chronic infections, cancer, congestive heart failure, chronic obstructive pulmonary disease, and HIV, cause syndromes that share many characteristics with accelerated aging and frailty, including sarcopenia, weight loss, the loss of energy, coupled with fatigability. Therefore, chronically elevated levels of circulating pro-inflammatory markers observed with aging are unsurprisingly also associated with similar signs and symptoms to those of chronic disease, although age-related symptoms develop progressively and over a longer time frame. The mechanisms of these actions are not fully understood, but a comprehensive analysis of the literature reveals that inflammation is often associated with a catabolic state. As described previously in this review, inflammation is associated with anabolic resistance in muscle, which is caused partly by inhibition of the perfusion adjustment to anabolic stimuli and partly by inhibition of IGF-1 production and signaling. Well, this is a little bit thing because the anabolic state is a regeneration state. The catabolic state that this refers to is likely a lack of a regenerative state. And the regenerative state or the anabolic state, not that the two are the same, would pose a fundamental resolution of the inflamed state, that is, sending macrophages to repair the system, activating the stem cells, and orchestrating that whole repair to fundamentally resolve the inflammation, which is inhibited with age. Chronic inflammation causes anemia via direct inhibition of iron absorption and recycling, as well as interference with erythropoietin production and signaling. Evidence indicates that inflammation causes insulin resistance, in particular TNF receptor superfamily 1A and toll-like receptor 4 block insulin signaling through Janus kinase activation, which causes serine phosphorylation of insulin receptor substrate 1 and 2, contributing to insulin resistance. Conversely, evidence also indicates that insulin resistance promotes the accumulation of M1 macrophages and fosters inflammation in adipose tissues through the production of CCL2. Pro-inflammatory cytokines, including IL-1 beta, IL-6, IL-11, IL-15, IL-17, and TNF, stimulate bone reabsorption and almost certainly contribute to osteoporosis. For example, bone reabsorption is increased in patients with inflammatory diseases such as rheumatoid arthritis. Studies in cultured cells show that IL-1 beta, IL-6, and TNF induced mitochondrial dysfunction and reduced ATP synthesis-driven respiration, reduction of the NAD plus NADH ratio, and reduced mRNA levels of PPARGC1A encoding peroxisome proliferator activation receptor gamma coactivator 1 alpha PGC1 alpha, suggesting that mitochondrial biogenesis is impaired. Studies conducted both in vitro and in animal models suggest that inflammation in general and IL-1 beta and IFN alpha in particular inhibit neurogenesis and reduce the magnitude of neurogenesis that is normally induced by exercise. These data delineate an overall mechanism by which inflammageing affects multiple physiological systems and phenotypes. During an infection that unleashes an inflammatory response, the physiological and metabolic state of an organism is focused on defense, and all other anabolic activities are paused, including non-defensive functions of the immune system, such as surveillance of damage, continuous repair in tissue, which mostly rely on growth factors. In this condition, if this condition is temporary, turnover repair of macromolecules, organelles, and cells can be delayed, avoiding irreversible damage. However, in older individuals, inflammation remains chronically activated, either because of continued stress from the inflammation source or because of a primary immune dysregulation. In the absence of macromolecular and organelle recycling, the accumulation of damage can reach a critical threshold, thereby causing severe functional consequences that become difficult or impossible to reverse, conferring the clinical syndrome of frailty. Inflammageing induces a catabolic state. Inflammation causes pathological states linked with frailty, cardiovascular disease and aging, sarcopenia. The induction of anabolic resistance in muscle inhibits the perfusion adjustment to anabolic stimuli, as well as insulin-like growth factor production and signaling. Anemia. Chronic elevation of IL-6 levels causes anemia through the production of hepcidin, reduction of the transmembrane ion transporter ferroportin, and inhibition of ion absorption and recycling, as well as interference with erythropoietin, EPO production and signaling. Insulin resistance, tumor necrosis factor receptor superfamily 1A, TNFR1, and toll-like receptor 4, TLR4. Block insulin signaling through Janus kinase activation, which causes serine phosphorylation of insulin receptor substrate 1 and IRS2, contributing to insulin-resistant osteoporosis. TNF, IL-1 beta, IL-6, and TNF ligand superfamily member 11 contribute to osteoporosis by stimulating osteoblast growth and activity, inhibiting the production of osteocalcin. Mitochondria biogenesis study in vitro show that TNF, IL-1 beta, and IL-6 induced mitochondrial dysfunction and reduced ATP synthesis-driven respiration, a reduced NAD plus NADH ratio, and reduced mRNA levels of PPAR, GCIA, encoding peroxisome, proliferator, activator, receptor, gamma coactivator 1-alpha, PGC1-alpha, suggesting impairment of mitochondrial biogenesis. Neurogenesis, pro-inflammatory cytokines interfere with the biological activities and neural growth factors such as brain-derived trophic factor, thereby affecting neurogenesis and plasticity. According to the addition of IFN alpha to human hippocampal progenitor cells reduces neurogenesis. These are just a few of how chronic inflammation promotes a catabolic state, suggesting a possible underlying hypothesis. During an acute bout of inflammation induced, for example, by an infection, the surveillance of damage and continuous repair function in multiple tissues are chronically inhibited, leading to an accumulated damage in organelles and macromolecules. Over time, the damage accumulation across different tissues and organs could become so severe that it cannot be compensated for and all causes irreversible frailty. So he's saying that this state jams the gear into a catabolic state, and then you don't get much repair. Conclusions. On the basis of the data and the hypotheses presented in this review, modulating inflammageing is a promising strategy not only to prevent CVD, but also to slow the decline of health that occurs with aging. Modulating inflammation is likely to be most effective at the early stage of health decline, at a time when compensatory capacity of the organism is not completely exhausted and might still counteract physiological and functional declines. New pharmacological treatments that selectively affect some of the signaling pathways that regulate inflammation are needed to balance the relationship between risk and benefits. Early treatments will require early diagnosis and availability of a signature biomarker profile that allows for a differential diagnosis between true inflammation and chronic inflammation sustained by the persistence of an infectious or toxic cause. Ultimately, RCTs are needed to test the hypothesis that modulating inflammation prevents the development of CVD, as well as multimorbidity, disability, and frailty. Key points. The key points are high levels of pro-inflammatory markers in the blood and other tissues are often detected in older individuals and predict the risk of cardiovascular disease, frailty, multimorbidity, and decline of physical and cognitive function. In individuals with obesity, visceral fat produces pro-inflammatory and chemotactic compounds and is infiltrated by macrophages, lymphocytes, and senescent cells with a senescence-associated secretory phenotype that contributes to inflammaging. Mechanisms potentially underlying inflammageing include genomic instability, cell senescence, mitochondrial dysfunction, microbial composition changes, NLRP3, inflammasome activation, primary dysregulation of immune cells, and chronic infections. Clinical trials suggest that modulating inflammation prevents cardiovascular disease, but studies to explore the effects of other chronic diseases, frailty and disability are scarce and controversial. Inflammaging can complicate the clinical features of cardiovascular disease in older individuals by causing an energetic imbalance towards catabolism and interfering with homeostatic signaling, leading to frailty. So the reason for this, inflammaging. Inflammaging is identified as a major thing to overcome in longevity and aging. And we propose here to break apart rapamycin because we want to get a more targeted polypill, that is mTOR inhibition without any immune effects, so we can get higher levels of higher blood levels of mTOR inhibition without being restricted by the immune system suppression. We want to then develop a pill specific for inflammaging, only inhibiting those specific elements of the immune system and possibly upregulating other ones, and put that together into a kind of synthetic version of rapamycin. How complex is this? How many different drugs are there required to bring the immune system into a more ideal state? Very complex. Inflammageing, chronic inflammaging in aging, cardiovascular disease and frailty, immortality, cryptocurrency, over and out.